Well, that was a great set of presentations. We have some time now for questions or comments.
Shelley Greenfield, UC Irvine. As you know, the specialty wars are gearing up. Sugar, blood pressure, prostate, and they're often vicious. And one of the themes that seems to be running through this panel and others is that primary care docs or generalists may be, how should we say, more open or more needy with respect to EMR-based heterogeneity models, basically something to help them out. Specialists maybe less so. And yet, so much of our conversation is about specialty medicine. Rod and John Spurtis mentioned two that are not always behaving so well. In fact, I'll just say one thing in digression, because I'm going to ask you what to do about this. But that is, between the American Association of Clinical Endocrinology, the most specialized diabetologists, the ADA, the ACP, and the VA, there's a gradient of targets in A1C. And the gradient is depending on specialtiness versus populationness. It's a good example of, because the ADA, after all, is a partly patient organization. The ACP is multivariate. So I wanted to ask you, should the concentration of organizations and payers focus really on as much as possible on primary care and the things that could be delivered through the EMR? Maybe that'll even make primary care more attractive. Any response to that?
So I'll say that I'm going to link your comment to Katrina's. There's so many decisions. What should we do, and how should we go about doing this? And it's my belief that it is important to think about what are the important decisions, and that can be on their impact on patient outcomes, the variability with which care is delivered to patients that are similar. It could be based on the cost of therapy, but we should figure out something, and then we got to get started. I mean, I can't stomach being around a room. Well, there's so many decisions, so much. Why should we even take a step forward in any direction? And we learned a lot from a trivial decision. I mean, drug-eluting versus bare metal stents was selected because I wanted to do, in fact, my whole career, from building the Seattle Angina Questionnaire to building the infrastructure to deliver risk models, was to create a world where you could say to a patient with stable coronary artery disease, you have stable coronary disease. Here's your risk of dying and having a heart attack over the next year with or without angioplasty, bypass surgery, or medical therapy. And here's your likelihood of being angina-free or having an improvement of angina at a year with all these therapies. So you could engage in a meaningful decision. You can't do that today because we're so unfamiliar with shared decision-making, and because you're always, goring somebody's ox? I mean, you're always, the interventionists aren't going to want it because you're taking away their procedures. The surgeons won't want it because you're taking away their procedures. We picked drug-eluting versus bare metal stents because we didn't think the doctors would really care what piece of metal they stuck in somebody's arteries. And it turned out they did. They cared a lot because drug-eluting stents are just by default better, and the impact on patients is irrelevant. So there's so much learning we have to figure it out. I agree we need to pick a few key areas to target, and we need to bring together a sort of multidisciplinary, multi-perspective stakeholder team to figure out how to do it. But then we have to start, building the tools and building a culture. Even at my own medical school, when I spent all this time on risk modeling, there's no course on really risk modeling or absolute risk reduction or tailoring treatment to risk in our entire medical school, and it's considered a novel medical school. So, we have to start familiarizing doctors with it. We have to have hospitals through value-based purchasing care about building the infrastructure to deliver it, and we just got to start, I think, not just delay and delay and delay because there's so many issues to think about.
I think that I agree with John completely, but you have to be realistic and pick your battles. If you think you're going to win every battle that is more political than scientific, you're going to be inefficient. I have the distinction, my colleagues tell me every time they recommend my name for a performance guideline committee, I get blackballed because I don't play well with others. Yeah, maybe the overlord part, which is okay. I don't like to travel, but I do think that you need to deal with the subspecialty societies. There's no other way. If you go around them, they will win the political battle. All it takes is one prominent cardiologist from Harvard say you're killing people, and they don't need data for it. So you need other cardiologists that are going to stand up and say, no, that's not right. There are, even with making fun of specialists, I found within every specialty there are people that really care about these things. You sit down and explain it, you lobby it. If you think, and the psychology literature is here that if you have the best argument, you will convince people, that's been disproved over and over and over again. You need multiple voices. You need to find people that are prominent, connected, but open-minded for these battles. The political battle is different from the scientific battle. It's hard enough to convince conflicted scientists who once said something that now is no longer seems true to change their mind. Think how hard it is in other settings. So you need to be willing to spend that time, and I spend a lot of my time trying to talk to people in the fields that I work in who have the subspecialty credentials to help. And that's true whether you're dealing with a subspecialty condition. Everything has somebody's special interest, right? Even if it's in the primary care setting to the subspecialty. So I think that's just a reality you have to deal with, and you need to put in the work.
And I'm just going to make a few comments. So I'd caution putting too much more on primary care. And, for better or for worse, our system is... there's a team managing the patient, at least for complex patients, and I'm not sure you can ask the primary care to do evaluating decisions that are made by specialty physicians. And so adding additional tools to the EHR may or may not be appreciated. It really depends on whether this is something that they're already planning on doing within their clinical practice. My wife directs all of our PCPs, and basically, her comment is that, one more EHR, intervention and the whole, system come crashing down, because we try to do a lot in that space. So I think you have to be really cautious right now. I think it would take probably about, 20 to 30 hours to make all the shared decision making that needs to be made in a 20-minute visit.
Jeremy.
Sorry, Jeremy from Ann Arbor. The tools of implementation you mentioned were all ones that predated heterogeneity. The tools you mentioned were all ones that predated heterogeneity, performance measures, decision support, and all have kind of mixed histories, right? No one's going to say the clinical decision support has been wildly effective. And then we're sort of layering another layer of complication on top of that. Can you talk a little bit about just first how you feel the tools necessarily might need to change for this new idea? And second, how much the difficulty we're having is just that clinical practice change is always difficult. Any new idea, the rule of thumb is 17 years. Rod was proud of getting something done in 12. How much is this just that's the way these things work, and how much is this that the tools have not yet really fully adapted to this particular type of change?
One of my favorite quotes is from Bill Gates, even though I hate Microsoft in general. And I think it's very true, is that people dramatically overestimate how much change they can make in 1 year and underestimate how much change you can do in 10. That's true in all of life. And this longer-term strategy is essential. When you get impatient, you're less likely to make change than realizing most changes take time. The only ones we implement fast is when the market is providing this, right? So you have a new procedure that makes a lot of money, a new drug that makes a lot of money for somebody, it might get implemented fast, but better value purchasing, cost containment, better discernment when there isn't that cash reward. You need patience, and you need a long-term strategy.
I mean, I'm not a cognitive psychologist to be able to understand that, but there are cognitive issues that really accelerate change. I mean, so percutaneous aortic valves in cardiology, I mean, that thing is taken off at a meteoric rate. Hospitals lose money, It's a relatively expensive procedure to do, but it's just taking off. And so there are examples of things that just, drug-eluting stents with no real data other than a less narrow artery 6 months later took off like wildfire when there was no real economic incentive. I think the challenge for us is how do you make this kind of, whether it's shared decision-making, decision support, heterogeneity being another layer of that decision support, sexy and exciting to do, like putting in a new percutaneous aortic valve? Can you create economic incentives? Because under a value-based program, delivering more efficient care makes more money for the institution. Can the institution share it other than through the bonuses to its CEOs so that the people doing the work are really incentivized? There's an opportunity for a lot of creative thinking about creating the incentives to accelerate the change that you're talking about. We just haven't been doing enough of that creative thinking to figure those out yet, I would think.
Maybe, Jeremy, if I could just add, I guess I would say I don't think there is there's always been heterogeneity. I don't think there's like a knowledge that all of a sudden treatment effects are variable. Jesse Berlin sitting in the back, he taught me this from basic biostat 25 years ago, right? And so I would just say that I actually think we've made huge amounts of progress. I think the progress is extraordinary. If I could argue one thing that's missing in making that progress, an enormous amount of my life is actually spent with the biological revolution, right? If you look at what Naomi was saying about targeted therapy, take imatinib, you take these other things. So we need to somehow bring this concept of there's a small effect we're trying to understand with the other revolution of understanding phenotype and the phenotypic differences, because a lot of what's going to end up driving the true behavior ends up being not being able to give them, no offense to John, like a number, and I love your green-orange thing, and it's great, but maybe it's a little bit, like Josh was saying, it's the biology of saying, there is a BCR-able translocation, and I can fix it. It's kind of like that ortho thing, And so I think if we could get there, we're going to drive behavior a lot more also.
We have time for one more question. Yeah.
Hi, I'm David Grossman. I'm from Kaiser Permanente, Washington, and was provoked by Rod's comments on overlords, so I feel compelled to say something in defense of the overlords. In full disclosure, I might be considered one myself. So just a couple of comments. Don't you think that, in fact, some of your comments are really fully directed at disease control measures, but in fact, I would argue back that the problem that you're pointing out to, which I think is a real one, is really more a derivative of the quality of the guideline-making process that actually is relied upon to actually develop those quality measures. So, for example, I'm actually on the NCQA Committee on Performance Measurement, and I've watched that sausage-making process in action. And I would say that, for example, all the preventive guidelines have a very tight link to the U.S. Preventive Services Task Force recommendations, almost no deviation whatsoever. And I think that most people would agree that the current process for trying to understand heterogeneity of treatment effect is recognized. I think the task force struggles to some degree, and as a former member of that, I can assert that that's absolutely the case, that we struggle with that issue, but primarily we're dealing with poor data. But if you say the reason the NCQA changed its quality performance measure from 40 and above for breast cancer screening to 50 and above was a direct reflection of the task force's recognition that 40 to 50 age group is really a C grade, meaning shared decision making. So we're not going to hold physicians accountable for it. We're not going to put them on that. So I think that, but on the other hand, for diabetes, it's a different set of guidelines. And even in prevention, American Cancer Society just recommended colorectal cancer screening consideration starting at 45. So how does a group like NCQA actually wrestle with discordant guidelines across organizations? So I would argue that the performance overlords are in part not where the problem starts. It starts higher up in terms of the consolidation of evidence and how it's adjudicated and put into a guideline format. Would you buy that?
In part, that I think there's a lot of blame to go around, including of us, right? And again, I said that mainly in jest, but in part because of this shifting of blame. U.S. Preventive Services Task Force does a better job. We've worked with them a lot over the last 5 to 6 years to really get their language better about these zones and how to do it. But up until recently, most of their guidelines were recommend here, recommend against here, and use patient shared decision making. I think they're making a concerted effort to do better. But my mentor, Avitas Donabedian, made it clear a long time ago something we forget. The job of setting standards in performance measures is inherently different from guidelines. We've conflated those, right? And we have done that. And those measurement groups have done that. The guidelines are supposed to guide clinicians and are just supposed to be guidelines. And when you adopt guidelines without thinking of how often there's exceptions, without thinking the evidence of absolute benefit, without thinking about costs, which most guideline committees turf, that is something. I got kicked off of NCQA committees because Shelley Greenfield, they're saying, oh no, he's going to tell this story, put me on a TEP, and I had unanimously convinced the entire expert panel that their blood pressure and A1C recommendations based upon guidelines would be wasteful and probably net harm, right? The NCQA disbanded that TEP, created a new one seated with people they wanted, took that to the board and got those passed, right? So maybe some of my history has some of these things. And I think it's wrong to blame individuals in any of this. We are all part of organizations that are guilty of things. University of Michigan is guilty of things. The VA is guilty of things. And I didn't try to make it individuals. I was sort of saying these performance measurement people should be holding themselves accountable, thinking of where they can improve, and not diverting criticism, just like I should as a clinician, general medicine should, all providers and all of us should do that. And that's what it was, you know. And so I think, yeah, we can all do better, and I think we should hold performance measurement groups accountable when they set perverse incentives. They set the incentives. They can say the guidelines are this, but we're going to focus here where it's most important. But don't worry, I feel guilty about things I don't do all the time. I'm a good Catholic.
Thank you, everyone.